Hi, this is Neil Hansen, and I'm taking you through a endometrial cancer MRI. So this is a pretty similar body protocol to the other body protocols that we've talked about in other videos. The one thing that's different, if we know we're doing a cervical or endometrial cancer MRI, is that we do the high-resolution T2-weighted images in the pelvis through the plane of the uterus. So instead of doing a straight axial, we would do the axial images through the short axis of the uterus and the coronal images through the long axis of the uterus. In this case, just due to the orientation of this uterus, it's almost a straight axial and coronal plane. The endometrial cancers tend to be kind of mildly T2 hyperintense, and you can see them best on these T2 high resolution images, although I'll tell you frequently after contrast you can see them also. Here you can tell that this mass is hypoenhancing relative to the uterus around it. So how is this protocol different? Well, in general, in addition to all your regular pelvic sequences, we get an axial, coronal, and a sagittal T2 high resolution image through the uterus. For preoperative planning and staging, it's very important to define the amount of myometrial invasion by the endometrial tumor, and so that's why we do these planes. You really don't know what the orientation of the uterus is going to be. It's frequently off normal anatomic planes, so doing all of those is crucial for getting good images and making sure that you know the exact depth of invasion. When reporting these out, I like to use a template because it's very, you have to give the oncologists and radiation oncologists very specific information. So in your template, which you can find under our body MRI templates, you want to measure the uterus in CC, TR, and AP planes. You want to look at the primary tumor and describe what it looks like. You're going to give an approximation of tumor size, and then for planning whether this person can undergo a uterine sparing surgical resection or not, you have to describe the amount of myometrial invasion. So that involves looking at the tumor and seeing whether it involves through less than 50% of the myometrium, 50% of the myometrium, or more than 50% of the myometrium, and describing it in detail to give the surgeons and radiation oncologists an idea of exactly where the tumor is. In this case, the tumor extended just slightly greater than 50% into the myometrium and also had extension here in the endometrial surface up to the fundus of the uterus. If we go back to our reporting template for cervical cancer, you also want to describe whether there is serosal extension of tumor as well as involvement of the vagina or cervix, because that significantly changes the stage of the cervical cancer and can change management. You also want to look at specifically the pelvic sidewall, ureters, bladder, and rectum, because advanced cervical cancers can invade all of those structures. Lymph nodes, if there's any pelvic internal or external iliac lymph nodes that are enlarged or morphologically abnormal, those should obviously be in the report because they change the stage of the scan of the tumor. And then if you see any distant mets, for example, if you saw anything in the pelvic bones on this scan, that should be mentioned in the report also.